Welcome to this clinical deep dive into the COPD playbook. In this session, we go through a structured framework for diagnosing, staging, and managing both stable disease and acute exacerbations. COPD is defined as progressive, non-fully reversible airflow limitation resulting from chronic bronchitis and emphysema. While cigarette smoking is the primary driver, always screen for occupational exposures and a positive family history. The genetic component also contributes to COPD. Suspect alpha-1 antitrypsin deficiency in patients presenting with early onset emphysema before their 50s, or a family history of the condition. It is classically associated with bacillar panlobular emphysema. Clinically, patients fall on a spectrum between two phenotypes, blue bloaters and pink puffers. Chronic bronchitis presents with a productive cough for 3 months in each of 2 consecutive years, often accompanied by labored breathing and cyanosis. On examination, signs of cor pulmonale, such as neck vein distension, a tender liver, and lower extremity edema, may be present. Emphysema is characterized by abnormal enlargement of air spaces distal to the terminal bronchioles with wall destruction. They present with worsening dyspnea and pursed lip breathing. They have a barrel chest due to hyperinflation and prolonged expiration. Auscultation reveals wheezing and distal breath sounds. Remember, most patients will have overlapping features of both. The gold standard for diagnosis is spirometry, a post-bronchodilator FEV1/FVC ratio of less than 0.7 is the diagnostic threshold and confirms the diagnosis. FEV1 percentage is the severity marker and is used to stage severity. And of note, the diffusing capacity is usually decreased. Chest radiograph and blood gas are not required for diagnosis and are part of the ancillary workup. Look for hyperinflation and flattened diaphragms on CXR, and on ABG, look for hypoxemia or respiratory acidosis. Differentials to keep in mind include acute bronchitis, asthma, bronchiectasis, cystic fibrosis, and CHF. Management follows a stepwise escalation based on GOLD spirometry criteria. The diagnostic foundation for all stages is a first-second forced expiratory volume to forced vital capacity ratio less than 0.7. Smoking cessation and annual vaccinations help regardless of the stage. As discussed earlier, staging is based on the percentage of exhaled volume in the first second, FEV1. Stage 1, mild. Use short-acting bronchodilators, albuterol or ipratropium for relief. Stage 2, moderate. Add a long-acting agent, either a beta agonist, a muscarinic antagonist, or a combination. Stage 3, severe. Escalate to a combination of long-acting beta agonist and inhaled corticosteroids. Stage 4, very severe. Add long-term oxygen therapy and consider surgical options. Adjunct and advanced therapies target specific clinical complications in stable disease. Beyond standard inhalers, pulmonary rehabilitation is critical for improving exercise tolerance. For patients with frequent exacerbations, consider azithromycin or roflumilast for prophylaxis. Surgical interventions like lung volume reduction decrease hyperinflation to improve lung mechanics and are reserved for severe upper lobe emphysema that hasn't responded to rehabilitation. This is a frequent exam topic. Only 2 interventions have been shown to increase life expectancy in COPD. First is smoking cessation, the single most effective intervention. Second is long-term continuous oxygen therapy, 24 hours per day for patients with a partial pressure of oxygen less than or equal to 55 millimeters of mercury or O2 saturation less than or equal to 88%. No medication, including inhalers, has been shown to prevent FEV1 decline. Recognizing an exacerbation. An acute exacerbation is defined by the cardinal clinical triad: worsening dyspnea, increased cough, and a change in sputum volume or purulence. Crucial finding: clubbing is not seen in COPD. If you see clubbing, you must investigate for alternative pathologies like malignancy or bronchiectasis. For hospital management of exacerbations, use antibiotics if the triad is present, bronchodilators, short-acting, corticosteroids, systemic, not inhaled, oxygen, target if hypoxic, non-invasive ventilation to avoid intubation. Distinct therapeutic guidelines separate acute COPD exacerbations from acute asthma. On exams, distinguish them by treatment approach. Systemic corticosteroids, oxygen, and combination bronchodilator therapy remain the same for both. Unlike asthma, peak expiratory flow, PEF, is not useful for monitoring COPD. Conversely, antibiotics are indicated for COPD exacerbations, but typically not for asthma. And the role of non-invasive ventilation is unclear in asthma, but useful in COPD. Patient stability and disease chronicity dictate the utility of corticosteroid formulation. Whereas inhaled steroids are useful in stable patients, systemic agents are useful in acute exacerbations. Never confuse these two uses. Again, inhaled corticosteroids are for stable, severe disease to reduce exacerbation frequency, but they have no benefit in the acute setting. Systemic steroids, oral or IV, are for acute exacerbations to shorten the length of the event. Note: 40 milligrams of oral prednisone for 5 days is equivalent to a 2-week course and is just as effective as IV if the patient can swallow. To wrap up, remember the 4 golden rules. Diagnostic anchor: use FEV1 over FVC less than 0.7. Mortality limiters: smoking cessation and oxygen are the only lifesavers. The steroid split: inhaled for stable, systemic for acute. The genetic red flag: suspect alpha-1 antitrypsin deficiency in early onset basilar emphysema.
This content is not intended for clinical guidance, use in medical clinics, or patient management. It serves as supplementary information for medical students preparing for examinations and should be used in conjunction with their official course materials. In the event of any discrepancies between this content and the prescribed curriculum, the curriculum shall take precedence until further review and clarification are made by the concerned students. The contributors to this video have exercised due diligence, but the content may become outdated quickly.